Hello everybody, thanks for watching. My name is Fabio Piscaglia, Associate Professor at the University of Bologna, Italy, and today I'm here with Jens Marquardt, Professor of Molecular Carcinogenesis at the University of Mainz, Germany. And today we're going to illustrate you briefly the highlights of the International Liver Congress 2018. This has been quite a relevant congress for liver tumors. And Jens, how many abstracts were submitted this year about liver tumors?
Actually, we had quite an impressive number of excellent abstracts, posters, as well as oral presentations. We're in total over 200, and they covered a broad range of different topics from preclinical models, applications, drug treatments to real clinical trials. So we cover the full range of liver cancer, indeed.
Yeah, but I think that today we have to focus on certain topics. So how was the selection made to present today the topics that we are going to illustrate? Could you briefly summarize?
So basically, I think we made a selection of what we found most clinically relevant rather than basic science. So practice-changing articles or things that are important for our daily practice. And I think we wanted to start with the relevance of treatment for hepatitis C and the new DAAs for hepatocellular carcinoma development as well as recurrence. And then I think we wanted to basically talk about the efficiency and cost of surveillance in selected patients, and then end up with some data on combinationary treatments as well as new signals from immuno-oncology.
Yes, thanks. I think that these were really the topics that have most impact on the clinical practice. So I think that for all of us, we would like to refine science, the academy, publications, but we want to bring home messages that we can apply on the next day to our patient. The first topic that we're going to touch is whether the achievement of sustained virological response affects the occurrence of first HCC in patients who had NODIT. I've seen that there is a Spanish study. Could you please illustrate it briefly?
Yeah, I found this pretty interesting. It's a late-breaking poster actually from Barcelona, and they looked at more than 1,000 cirrhotic patients treated with different DAA regimens, and basically what they saw is that incidence rates were roughly 3 to 4%, and associated with poor liver function and also non-characterized lesions in imaging, so something that also other studies showed. But what is probably particularly interesting about this study is that they compared the incidence rates on de novo carcinomas to those that occurred in the HALC and EPIC trials. So they compared the DAA to the interferon-treated patients, and they saw that there was a much higher rate of HCCs in these DAA-treated patients in comparison to the interferon era. And I don't know how well they matched the patients, but this is certainly something that should raise question about the safety of the DAA in cirrhotic patients. And there's a couple of more data, and I think you also saw.
Yes, I think this is the point that you raised based on this poster presented by Maria Rig and colleagues, is the point that when we compared the sustained virological response achieved with direct antiviral agents and with interferon-based agents, potentially there are different populations that have been treated. And this is a topic which is difficult to clarify. So there is a French multicenter study, which is PS020, that tried to address this topic. They utilized a very large database of prospectively collected patients who were submitted to antiviral treatment. This is a very large study as well, with more than 1,000 patients. And they compared three groups: those who did not achieve sustained virological response, and these were mainly the patients treated by interferon, that we know even in this study did not achieve in cirrhotic patients, because this study is on cirrhotic patients, did not achieve sustained virological response in more than 45% of the patients. So we have more than 50% who did not achieve sustained virological response. Then we have the patient who achieved sustained virological response with interferon-based treatment, and the third group who achieved sustained virological response with DAA, which is in the range of 95% of achievements. And if you look at the rough numbers, the patients who do not achieve sustained virological response have overtly higher incidence of HCC. So the first message is, if you achieve sustained virological response, you decrease the incidence of HCC. And I think you agree on that.
I think
this
that
is
is
our experience.
very clear.
Then the second question is, if we treat and achieve with DAA, do we get a higher incidence than with interferon? And the question behind is that interferon is an immunomodulatory drug. So it might act on the environment and might affect the incidence of HCC. And if we look at the crude numbers, the incidence in SVR with interferon was in the range of about 3%, a bit more, and with DAA 4%, a bit more. So you might raise the question whether there is indeed an increase. But this group performed a propensity score analysis, which is a system to match two different populations to make them similar, and even adopted the inverse treatment weighting probability, which is an additional statistical methods to make the two groups comparison. And after this matching, indeed the patient who were treated with DAA did have an incidence which was absolutely comparable, even if not a bit less than patient with SVR under interferon. I think this is a very interesting study.
So I would certainly agree with the fact that SVR, and I think there's no doubt, significantly reduces the incidence of HCC. And with regards to the de novo carcinogenesis in DAA versus interferon, I think probably overall the risk is a little bit higher due to the fact that you treat more advanced liver diseased patients. But if you match up quite well, probably these differences will disappear or at least be only slight. But what I found extremely interesting was also a study that looked at the effect of SVR in decompensated patients. So patients that were decompensated or at least child B7. And again, also in this cohort, there was a significant reduction in the incidence of HCC as compared to non-SVR patients. And what I found pretty nice was the fact that, and that was seen in other studies as well, that you had a MELD decrease of 3 or more in roughly 25% of the patients. So indeed, there seems to be a little bit of a fibrosis regression or cirrhosis regression that basically improves liver function, whereby you would probably also reduce the risk of HCC development.
Okay, so I think that all these three abstracts go in the same direction, and the message delivered at this Congress is that if you achieve an SVR, you reduce the incidence of HCC. Even in patients who achieve an SVR, the severity of the disease, namely the decompensation or portal hypertension or presence of diabetes, still maintain a higher risk of HCC, but there is no effect of the type of treatments on letting the first occurrence of HCC take place. I think this was a clear message of the three abstracts together. I think this is something that we can bring home for our clinical practice from tomorrow. So in patients that have achieved an SVR, there is still an open issue because the effect on the immunomodulatory environment created by hepatitis C might raise a question whether even though the occurrence is the same, the type of tumors might be more aggressive or less aggressive. And this topic was touched by at least two studies. I've seen there is a study by the Lope and colleagues from Spain. What does it tell?
So indeed, several studies raised the question whether the treatment with DAA would change the natural course of the disease and make the tumors more aggressive. One thing that De Lope et al. Touched is the fact that treatment in general led to diagnosis of tumors at earlier stages and enabled more curative treatments. But when they then compared interferon-based regimens to DAA-based regimens, initially they found that indeed the DAA treatment led to a more favorable biology as opposed to interferon. But probably, and this is what they then looked at a little more closely, was the fact that adherence to surveillance had an impact on the characteristics of the tumors, and when they adjusted for only patients that have been under active surveillance, these differences disappeared. So probably both interferon-treated and DAA-treated tumors have a similar biological behavior.
That's interesting, and this is in keeping with the study of Vitali and colleagues. This is an Italian multicenter study which focused on patients who were treated by surgical resection either after achieving SVR for hepatitis C or with replicating hepatitis C. And they look at the pathological features, whether they differed, because clearly what you mentioned, that the potential more aggressiveness after the achievement of a SVR might be in place, and this could be demonstrated histologically. And the finding was there was no difference. They were similarly in size, just a bit smaller after DAA, but the rate of microvascular invasion grading, it was exactly comparable. So in the end, the conclusion would be that there is no difference. Clearly, a question remains open for those cases who have not been resected. But in my experience, there is not such a big number of patients who have first occurrence in non-resectable stage just because they were treated with DAA. But this is still an open issue. However, there is an additional interesting topic that they assessed the post-operative course, because clearly beyond the grading and the tumor characteristics which affect the long-term outcome, you have costs related to the length of stay, and the patient who had achieved a sustained neurological response had shorter length of stay, and in the end they cost less because they do better after surgery because the liver works better. So I think this is not a secondary point that we have to consider, because if you have achieved a sustained virological response, probably you could live longer if, as it is demonstrated, you have not a more aggressive tumor, just because your liver function does better. And probably in the future we have more opportunities to treat patients with more aggressive treatments because they can tolerate with the liver function. So I think this is the first step to a very interesting topic.
Fabio, do you remember around 2 years ago at the ILC, there were a couple of studies that basically make a note of caution for the use or the safe use of DAAs in patients that have been previously treated for HCC, either by resection or ablation. And if I recall correctly, they really showed that these tumors would recur at a very high pace and very high frequency. And I think there's a couple of studies here at ILC that address exactly that issue, right?
Yes, this has been really a great fuss for the scientific community. These were 2 studies published in the springtime of 2016 in the Journal of Hepatology, one from Barcelona, one from our own hospital, reporting a rate of recurrence in the first year after achieving SVR of about 28 to 29%. So the question has arisen whether there is an increased risk of recurrence. This is a different topic. We discussed there is no increased risk of first occurrence, but maybe if we treat patients after they've been cured for there's been an elimination of the tumor, there is an increased risk of recurrence. And there are 3 large Italian studies that address this topic. One is the study by San Giovanni. This is a study of the Italian Association for the Study of the Liver, which enrolled about 1,200 patients. Out of these patients, about a bit more than 100 were patients who had been treated with curative treatment, achieving complete necrosis for previous HCC. So the incidence of recurrence in this study was again in the range of about 30%. Then there was a second study by Leo et al. That reported in a rate of about 5% of all the population of nearly 2,000 patients, of patients with previous HCC. So again, about a bit more than 100 patients. And they reported a rate of incidence of 24% of recurrence in the first year. And the third study presented by Gambato et al. This is again another Italian study that only focused on a patient who had been treated. And this study reported an overall incidence of 32% over almost 2 years, so approximately in the range of 23 to 24%. And these were mainly Child-Pugh A and mainly treated in the early and very early stage. So altogether, we can summarize that with over 300 patients, which is a consistent number of cases, the recurrence in the first year is in the range between 22 and 28-30%, similarly or a bit lower than previously reported. This is not the definitive answer, because clearly it's very difficult to compare patients with the historical series. So the strongest series probably is the one of the STORM study, which is a trial investigating the recurrence of patients in after resection or ablation at high risk of recurrence, either treated or not with sorafenib, but with a failure of sorafenib to reduce the recurrence. So we can utilize the whole series, and the recurrence rate was in the range of 20% in the first year. So this is not the definitive answer, because apparently the incidence is still slightly higher in all these studies. However, there is at least one message. There is not for sure a big increase, if any, in the incidence of HCC. And the question remains open because the STORM study included several etiologies. Here we have one single etiology, which is hepatitis C, and we don't have a clean enough historical series to assess what would have happened to this type of patient as a recurrence. So I think we have to maintain a word of caution, speak with our patients if we decided to treat with DIA for hepatitis C, but I think that there is no big issue that we are really going to impact on the recurrence. Whether the type of recurrence differs in terms of aggressiveness is still not investigated by these trials. Maybe in the next EASL there will be some more information on this.
You know, in line with this and the recurrence rate, the clinical scenario of liver transplantation and DAA treatment is also something that needs to be discussed. And there's actually a multi-center study that looked at 94 HCC patients that have been treated on the waiting list with DAAs. And then they look for recurrence rates. And basically, the safety signals are actually quite promising. So first, SVR was absolutely comparable, over 95% in those patients. And secondly, incidence rates after transplantation was absolutely comparable to those observed in normal HCC patients. And really, the tumor burden was the only thing that was associated with incidence or recurrence of HCC in those transplanted patients.
I think these are very important data because there is still an open question whether they potentially slightly increased incidence of recurrence or whether there is a more aggressive pattern of recurrence, which has not been established to date, is clearly related to some immunomodulation. And patients who are transplanted undergo immunosuppression. So this was a burning question. If we treat patients before transplantation, are we exposing them to a higher risk? However, it seems that these information that are reassuring are now limited to patients the Malan criteria, because I guess these were mainly patients in Malan criteria.
Yeah, that is correct. In this study, they only treated patients within the Milan criteria. So I guess you're absolutely right. It is, as of today, it's unclear whether the size of the tumor or extent of tumor growth would impact the recurrence rate after DAA treatment if you exceed Milan criteria. And I'm not sure how you do it, but we tend to not treat the patients with HCC on the waiting list. We just wait after transplantation.
This is still an open debate. We decide case by case, but I think this highlights that there is no standard of practice, although we tend to treat. So this is discordant, and I think this is something that we hope will be solved by the next ELC next year with maybe some data. Okay, so I think there are some more interesting topics, and one is the cost effectiveness. So we're now treating all these patients. We've seen that there is a an improvement in the rate of incidence of HCC. So it's still worth to treat these patients. What do the studies say? I've spotted an interesting study on hepatitis C, but this applies also to, for instance, other etiologies like stopping alcohol. For what concerns hepatitis C, there is a study showing, providing a cost-effectiveness analysis, so an estimation of the incidence of HCC, whether you treat patients at the cirrhosis stage or at F3. This is relevant because the guidelines today recommend to surveil patients with ultrasound at 6-month intervals, even though they are only in the severe fibrosis stage, not in cirrhosis, because they are surveilled over time, and it is very difficult to assess when there is the time of the transition from F3 or to F4, and there is a risk of understaging. I summarize very briefly the message. If you had already cirrhosis, you must maintain the surveillance because this is cost effective. Whereas if you were F3 and you have achieved sustained virologic response, there is a drop in the risk of developing cancer. And since you are no more progressing, at least if you have no other comorbidities like diabetes, you are no more progressing to cirrhosis, you are not anymore cost effective to receive surveillance. So I think this will not be easy because sometimes the patient are expecting to continue what they have been undergone so far. But from the nationwide cost effectiveness approach, in the future probably we will need not to let the patient with only severe fibrosis but no cirrhosis who have achieved sustained virologic response to maintain the surveillance. And what about the alcohol? If the patient stopped drinking, is a similar aspect?
Yeah. I think, the matter of comorbidities becomes actually pretty important in this scenario. And I think we agree on age, overweight, and several other factors. And now, basically, from our discussion, we can conclude that if you have an SVR, you reduce the risk of HCC development. And similar data we also know from hepatitis B patients that you treat with antivirals, the risk of HCC development is actually also significantly reduced. So what about the alcohol? What's your question? And there's one study that actually addresses exactly that. And they have several hundred patients, alcoholic cirrhotic patients, that they basically observed in a routine surveillance program. And half of them managed to stay abstinent, completely abstinent from alcohol. And the interesting part of this study is that once you reach the cirrhosis level, the incidence of HCC in the abstinence and non-abstinence patients was absolutely comparable. So in the case of a fully blown cirrhosis, the alcohol, the risk factor, doesn't play that much of a role. The cirrhosis actually drives the risk for cancer development. However, it is very worth mentioning that as we saw in the studies that we discussed, that the impairment of liver function is a big problem in terms of HCC incidence. And in that particular study, the stage of liver disease was actually quite high. So roughly 80% had varices and more advanced cirrhotic stage. So there seems to be a point of no return where the cirrhosis is more the bigger determinant of HCC incidence than the alcohol as a risk factor.
Okay, I think so. This data seems to be consistent. The one that you mentioned is PS064, the study about alcohol. The one that I illustrated is PS061. And I think that you correctly mentioned that there is a point of no return once you have cirrhosis. Even if you remove the etiology, this patient has to keep on undergoing surveillance. I think this is a clear message of this Congress. The last point that is worth to be mentioned is how can we improve by treating HCC the survival of our patients. At this Congress, there have been no really breakthrough in the drug treatment. However, there have been a couple of attempts to combine different treatment modalities. And I think this is a way that is difficult to standardize. So even in the guidelines, you won't find the recommendation about the combination. but it is at least of interest to understand the potential of these therapies. I've seen that, for instance, external radiation beam therapy has been investigated.
Yeah, so I mean, throughout our discussion, we've been mentioning how important it is that the liver function is well maintained in terms of incidence, of recurrence, but also in terms of treatment. So many of our patients actually are not eligible for curative resection due to the impaired liver function. And then we also know that when the tumor reaches a certain size, then like local ablation is not as effective as it probably should be. So there's a couple of studies that try to combine different local treatments. And here at ILC, there's 2 studies that we found particularly interesting that addressed the question if the combination of TACE and local stereotactic body radiation can improve the outcome in patients that have bigger tumors between 5 and 8 centimeters. And one study by Buchstein et al., they presented data from a phase 2 trial where they treated 20 patients, mainly with good liver function, but in a very standardized manner. They performed 2 TACEs with DC beads, and then in a period of 2 to 3 weeks, they performed the SBRT and applied 35 to 50 grays. And basically, they showed that this combination treatment yielded in a very high rate of objective responses, almost 95%, and roughly 80% of complete responses, and only 5% of the patients actually progressed under this treatment. And the other study from Korea, they had a similar setup, not as standardized, but still they compared SBRT and TACE versus patients that were matched with TACE only. A little more patients, 100 to 80. And again, the signals were also quite promising. They had a very high number of objective response rates and a progression-free survival. However, overall survival did not reach statistical significance, but it is probably also very difficult to match these historical TACE patients with these TACE SBRT patients. So overall, I think quite promising data in terms of combination of TACE and SBRT.
I think this is a very interesting study, both, but are still a bit preliminary because of the difficulties. I think it's important what you mentioned, that the survival was not affected, because clearly any treatment of HCC in patients with cirrhosis has to balance the potential detrimental effect on liver function with those in achieving a response. So I think these are promising, but we need more studies, and at best they should be randomized even in phase 2. And I think the topic of radiation effect on HCC is very interesting, and indeed there was a very expected and awaited study, which are the final results of the Soramic study. Mm-hmm. We were all very eager to look at these data because these were in place since years, and we know that in patients with advanced HCC or unsuitable or refractory to TACE, there is still a need to improve life expectancy. Today we treat them with sorafenib, and the Soramic study investigated whether adding internal radioembolization with E90 to sorafenib could extend survival. So this was a very well conducted study, randomized study, and the patient were either randomized to sorafenib alone or sorafenib plus radioembolization. Against our hope, rather expectation, there was no survival benefit. So unfortunately, we have no new standard of care for treating our patients, and we will maybe wait for a better tailoring of these treatments, potentially for more limited portal vein involvement. But clearly the message today is that systemic treatment alone provides the reference standard for treatment, and there is no advantage in letting this patient undergoing radioembolization, especially considering that new drugs, second line, third line, are coming on the market. So we need to keep and preserve liver function. And I've spotted that there is not much, but we are all very interested about the new drugs that it does just touched, and one is nivolumab. So one issue is about the safety of nivolumab. Something has been presented here?
Yeah, there's actually an update on the Checkmate 40 study, and as you said, we always need to look if we potentially induce detrimental effects to the patients when we treat them. And so they presented the extended follow-up on those patients after 15 months of treatment. And basically, and that is something that is, I think, very promising and also good to know, is that there were no new safety signals from these patients. And all of the, in particular, hepatic-related adverse events, even grade 3 and 4, they all resolved, and none concerning new safety data was presented. And objective response rate remained stable at around 15% in pretreated, sorafenib pretreated patients, and the disease control rate again was roughly 50 to 60%. So in terms of safety, very, very good signals also from the Checkmate study.
Okay, that's important for our patient to be safe, but we still clearly need to wait for the final results for survival, because in this crucial setting of a tumor arising in a diseased liver, we need to look at survival and not just at the response rate or safety. But that was really very interesting data. Thanks, Jens, for spending the time on this very interesting topic with me.
Thank you very much. It was indeed a big pleasure.
Pleasure for me. Thanks to all of you for watching, and please don't forget to access the HCC guidelines, clinical practice guidelines that have been just released on the Journal of Hepatology. Would be a lot to read and a lot to learn. Thanks, and meet you at the EASL next year, 2019.